So what I'd like to do is to begin by giving you an idea of what we're going to be covering today. So first we're going to be talking about the roots of anger, how the brain reacts to threat. Because if we can understand how anger is, if you will, how it emerges, and what the precursors of anger are, then we're going to be in a much better position to understand our clients and also perhaps to change things, to derail things. How and where and when does anger arise? So we're going to be looking at the different kinds of clients, and I'll be talking about, in particular, psychological and psychiatric clients and the kinds of diagnoses where anger is a part of the symptom pattern. There is currently not an anger diagnosis. The DSM-5 did not choose to have an anger disorder within the diagnosis. We have something called intermittent explosive disorder, which basically applies to a relatively fewer number of individuals and probably involves some misactivity within the brain in terms of inappropriate firing of neurons. So we'll look at medical populations as well, and we'll look at the different ways, the different disorders, injuries, brain injury and so forth, where you're likely to encounter anger in your work and its expression. Okay? We're going to look at key components of regulating anger. When you're confronted with discontrol, some of you may actually be treating people as a psychologist or social worker or therapist, or you may be a counselor in a school, or you may be working in an employee assistance program, or in a hospital setting where you want to kind of identify strategies that can be helpful for so-called anger management. And a lot's been written about that. The strategy we're going to talk about today comes from my book, Taking Charge of Anger, which I'm proud to say went into a second edition. It's sold pretty well. And I originally talked about the STOP model, stop, think, objectify, and plan. And we're going to talk about the rudiments of implementing anger management within that model, and try to give you some tools that are very practical that you can take with. Okay? Next, we're going to talk about when you encounter anger, or when your clients encounter anger, rules of engagement. When you confront somebody, or when you are working with a client or patient who is potentially violent or aggressive. You know, as human services workers, sometimes we're not equipped or prepared very well to deal with anger directed at us. You know, it's very difficult. I remember giving a seminar in Chicago about 5 or 6 years ago, and I was talking a little bit about things you can do to diffuse a provocative situation, right? And a gentleman raised his hand and stood up, and in the next 5 or 6 minutes mesmerized the entire audience, because he talked about what had happened to him. He was a psychologist who was practicing in one of the Chicago suburbs, and he was working with a couple. And they were having some, pretty serious discord in their relationship. And in any event, he felt like he wasn't making good progress. And this one evening, he was at home and he got paged. And his answering service said, there's a suicidal patient, you need an emergent situation. So he called up this gentleman within the relationship who said, Doc, I've got to see you. I've just got to see you. It isn't working. She broke up with me. And I don't know if I can survive this. I'm really thinking about killing myself. So, practicing the good empathy that we all practice, he agreed to meet the client at his office. They were going to be the only persons there, so he heads off to the office. And by the time he arrives, the client shows up, and it's clear he's been drinking alcohol, a considerable amount of alcohol. And so this psychologist begins the session, and it goes from tearfulness to rage. You let me down, if you'd have done a better job, this wouldn't have happened, something like that. And so he attacked the psychologist and broke many of the bones on the right side of his face, pummeling him. And to make a long story short, he had to endure many months of some reconstructive work and some work on his TMJ and other kinds of things. And so he shared this, and he talked about how now he was suffering from post-traumatic stress disorder. And he would begin to feel anxious any time a client would start to raise their voice. And he found that he was unable to work with a lot of people because anger is pretty prevalent. You know, it was pretty tough to be a psychologist and have a hard time working with anger. So, of course, he was in treatment now. And that led to a lot of discussion, I think, among the audience about how that, and I think at the end of it, not to keep you in suspense, but I think everyone agreed that number one, if a client's been drinking alcohol, you don't have a session, you do everything you can to get them into a cab and get them out of there. But number two, going after hours to your office with no one present in a case that has risk factors, and I won't go into it, we'll talk about risk, and this did. So we all agreed it would have been better for the psychologist to meet the client at the emergency room. Pick a hospital, meet them there. If the client is unwilling to meet you at an emergency room, don't meet him. Does that make sense? Yeah. And we'll be talking about ways of diffusing confrontations. Okay, let's continue on. Then we're going to talk about collaborative communication to reduce conflict and resolve issues. And here we're going to be focusing a little more on partner relationships or relationships with other folks, where anger is a symptom of important needs not being met. And how can we help folks communicate their way through these thorny paths, if you will? How can we help them to reach resolution? What I call collaborative problem solving, or a win-win resolution. And this may be true in conflict that you might have with a colleague, you know, or certainly with a client, or you know, a patient comes into the office and is very, very angry about the course of his or her treatment or paying the bill or something. And it goes on and on. I have folks here I know from a lot of different areas of contribution. So I think you'll find that, I hope, helpful. Then finally, setbacks are not if they occur. In my experience, it's when they occur. Because, as we'll see, many of the patterns of anger and expression of anger that we're going to talk about today come from long-standing, both genetic roots, developmental roots, experiential roots, biological foundations, and so forth. And things are not going to change, in many cases, even if you're the best therapist or nurse or whatever, and you're working with this person, they're not going to change overnight. And so the issue about setbacks is, how do we diagnose what happened? And how can we sort of redirect treatment and get the client back on track, as opposed to, you know, I'm back at base one, or I feel like I failed. So I actually go over that with clients, and I let them know that if that should occur, what to look for, and the fact that you're absolutely and essentially invited to come back, and let's talk about it. It's nothing to be ashamed of. So let's talk a little bit. I could talk for quite a period of time about the issues related to anger in our culture, but a few things to be aware of. About 11 to 16% of women report violent aggression by their partners. Murray Strauss has done a lot of really excellent research in this area, but I think we would all agree that that's downright unacceptable. More common in dating couples, Dan O'Leary's work, men and women are equally violent. Now, that's not a politically correct statement, but men and women get very, very angry and can be verbally aggressive and so forth. But women are much more likely to be injured. And so the problem here is that while women may get angry as often as men do, it's how the anger gets handled, and also there's a clear difference in terms of physical strength and the like. Men are more likely to use violence to terrorize and victimize women for self-defense. That's based on some research by John Gottman, who you may be familiar with. Just a couple more of these. What's the most important predictor? Previous violence predicts between 46 and 72% the probability of future violence. The more frequent and intense, the greater the probability. We'll be talking later about, Dan O'Leary, about risk factors. Partner violence, this is probably the most important reason I presented this slide, because health professionals most often do not detect anger issues, the potential for violence in a relationship. And one of the reasons for that, we're getting better and better at it, and in many settings, you are asked as part of a protocol, if you have been the subject of abuse and that sort of thing. So things are improving in this area, but basically about 50 to 60% of couples who present for marital counseling have had an episode of violence, but on intake, only 6% of women reported it. When followed up with the right kinds of questions, it rose to 44%. So we want to be sure. I teach a course for first-year medical students at Georgetown, and we get a lot into how to go about gathering information. Now, all of us know, like the back of our hand, asking open questions versus closed questions. But we have to be willing to ask questions about alcohol, about sex and sexuality, and about violence. And sometimes it's a little uncomfortable. And to follow them up, sometimes asking a question that is an assumptive question, like couples often touch each other when they get angry. I wonder when the last time was that happened in your relationship, is very different from, is there any violence in your relationship? What's the answer to that question? No, right? How about alcohol a problem? No.